Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, I'm Terry Mamines, Medical Director of Breast Program and Research Activities at the Advent Health Cancer Institute and Professor of Surgery at the University of Central Florida College of Medicine. Welcome to this activity titled, How Many Lymph Nodes Are Involved in This Patient with Hormone Receptor Positive, HER2-Negative Early Breast Cancer. So let's put this in context of a patient. So the case that we will present is a 64-year-old healthy female who is diagnosed with an invasive ductal carcinoma, grade 2, 4 centimeters in greatest diameter clinically, estrogen receptor positive 90%, progesterone receptor positive 80%, and HER2 negative 1 plus by immunohistochemistry. So the patient undergoes lumpectomy and sentinel lymph node biopsy, and she's found to have an invasive ductal carcinoma grade 2, as we expected, 4.2 centimeters in greatest diameter, and 3 out of 4 sentinel lymph nodes are positive for macrometastasis. So the clinician suspects that more lymph nodes may be involved and that the tumor is more aggressive than the initial findings suggested. So can we better estimate risk of recurrence for this particular patient? So of course, it's fair to say that axillary ultrasound has become a very important tool in estimating the status of the axilla for patients with early stage breast cancer, and also a useful tool to minimize the likelihood of finding 4 or more positive nodes on a sentinel lymph node biopsy. Several studies have shown that the rates of PN2 or PN3 disease are very low, 0 to 3%, if there is a negative axillary ultrasound at the time of diagnosis, versus 8 to 31% if the ultrasound had shown suspicious findings. So ultrasound is useful in actually evaluating the status of the axilla and also evaluating the potential burden of disease in the axilla. On the other hand, breast MRI, which we commonly now use for early-stage breast cancer, has low sensitivity and specificity in detecting subclinical axillary involvement. MRI can detect, of course, clinical involved lymph nodes, but for subclinical lymph nodes, it's not very good. And so is PET-CT. Has very low sensitivity in detecting microscopic lymph node involvement, so it's not very useful in the local staging of the axilla. Of course, it's fair to say also that the most accurate assessment is to pathologically examine the axillary lymph nodes by performing essentially an axillary lymph node dissection. However, as we all know, axillary lymph node dissection is associated with increased morbidity. So what are some of the downsides to perform an axillary lymph node dissection in this patient? Well, we know that axillary lymph node dissection has significant morbidity in terms of painful neuroma, in terms of dysesthesia and hypesthesia of the axilla and the inner arm. Occasionally we see postoperative seroma. And of course, there is also increased incidence of breast edema, particularly if it's accompanied by breast irradiation, which usually is the case. Breast cancer-related lymphedema is an important potential sequela from axillary treatment and is elevated not only with axillary lymph node dissection, but also with axillary radiotherapy. So in this important paper in JCO in 2020 by Naum et al., they estimated the risk of breast cancer-related lymphedema according to the surgical procedure and according to whether radiotherapy is used. So when you look at these numbers, we can say that between sentinel lymph node biopsy and radiotherapy, or axillary lymph node dissection radiotherapy, is typically how we would approach patients. What about input from other disciplines? How do other disciplines can weigh into how we manage this patient? Obviously, from the surgical oncology standpoint, we know from many studies, and I'll show you some data in a minute, that axillary lymph node dissection provides no significant benefit in local control, disease-free overall survival in this setting, only just increased morbidity. From a radiation oncology standpoint, we know that there is regional nodal irradiation provides benefit in local control, disease-free overall survival, whether additional lymph nodes are involved or not, for example, in this patient. In other words, patients with 1 to 3 positive nodes get benefit, as well as patients with 4 or more positive nodes. So radiotherapy probably will be given no matter what the number of nodes were, and I'll show you also some data on that. And from a medical oncologist standpoint, the question that medical oncologists, or we asked our medical oncologists, would additional positive nodes alter your systemic therapy? What would you do for these patients if there were additional positive nodes in an axillary lymph node dissection? So these are data from the overview analysis looking at studies or trials which compared more or less axillary treatment, and they did so in the sentinel lymph node biopsy era. And as you can see, in terms of local regional recurrence and distant recurrence in this slide, both for node-negative patients or for node-positive patients, the additional surgical axillary treatment, which was essentially axillary lymph node dissection, did not provide any benefit in local regional recurrence or distant recurrence. Also, there was no evidence of benefit in breast cancer mortality or any death, whether again node-negative or node-positive, with more axillary treatment. Now, what was different though was rates of lymphedema. Clearly, more axillary treatment increased the rates of lymphedema to a tune of about 2.4 times. So it doubled and a half the rate of lymphedema if you did more surgery versus if you did not. And of course, other studies included in the meta-analysis were studies comparing axillary dissection with axillary radiotherapy. And when you look at the outcomes in terms of local regional recurrence, distant recurrence, or breast cancer mortality, or any death, there was no difference between axillary radiotherapy or axillary lymph node dissection. But what was different was that axillary lymph node dissection compared to axillary radiotherapy significantly increased the rates of lymphedema, with a hazard ratio of 1.79, which essentially 70% increase in the rates of lymphedema if you did an axillary dissection versus if you did radiotherapy. So what about the medical oncology aspect of this? Well, we have several trials that recently have informed the treatment of ER-positive, HER2-negative breast cancer and whether there is a need for extra axillary assessment. So as you know, the Exponde trial evaluated the addition of adjuvant chemotherapy to endocrine therapy for patients with hormone receptor-positive, HER2-negative breast cancer that had 1 to 3 positive nodes and had an oncotype DX score of 0 to 25, and randomized them to either chemotherapy followed by endocrine therapy or endocrine therapy alone. The axillary staging required to enter the trial could have been a sentinel lymph node biopsy or axillary lymph node dissection. So in that trial, about 37% of the patients, I will show you a little bit later, entered with sentinel lymph node biopsy alone and had 1 to 3 positive nodes. So it could have been that some of these patients may have had more nodes that were not dissected by an axillary dissection. There was also a group that entered with an axillary dissection that had 1 to 3 positive nodes. So the results of the Exponde trial clearly show that for postmenopausal patients with a recurrence score of 0 to 25 and 1 to 3 positive nodes, there was no benefit in terms of invasive disease-free survival. The postmenopausal patients, like the one we're dealing in this case today, had no benefit from chemotherapy. And this was true whether patients had 1 positive node or 2 to 3 positive nodes. And as I mentioned before, those with 2 to 3 positive nodes could have had more nodes if they had axillary dissection, but some of them did not. 37% had just the sentinel lymph node biopsy. Nevertheless, again, you don't see any benefit in terms of number of positive nodes. Monarchy evaluated adjuvant abemaciclib for high-risk hormone receptor-positive HER2-negative breast cancer patients that had 4 or more axillary nodes, or 1 to 3 positive axillary nodes and tumor size 5 centimeters or greater, or grade 3, or Ki67 20% or more. And the results of the study showed that, in fact, the addition of abemaciclib significantly improved the primary endpoint of invasive disease-free survival. At 5 years, there was a 7.6% absolute improvement So a patient like we have here, potentially because it doesn't have 5-centimeter tumor, doesn't have grade 3, so it doesn't technically qualify for the monarchy trial, unless potentially there were more positive nodes in the if she had an axillary dissection. That is the crux of the argument here. So going back to our case here, how does performing axillary lymph node dissection may alter patient management based on their exponent results? As I mentioned, about a third of the patients, 37%, had only sentinel lymph node biopsy and may have had more than 4 or more positive nodes. However, as I mentioned, there was no difference in chemo benefit by axillary surgery or number of positive nodes. And of course, what if a patient had 1 to 3 positive nodes, like our patient here, but then gets an axillary dissection and has 4 or more positive nodes? Obviously, for postmenopausal patients, still giving adjuvant chemotherapy can be considered if you have 4 or more positive nodes, even with a recurrence score of 25 or less. However, such approach has uncertain benefit because we have some other indirect data that even 4 or more positive node patients with a low genomic score may not benefit from the addition of chemotherapy. Now, why do we want to give chemotherapy for patients with 4 or more positive nodes? Because they have higher risk. But do they really have higher risk if they have a low genomic score? So here we see data from one of the NSABP slides that evaluated adjuvant chemotherapy in the 90s, the NSABP B28, either AC or AC followed by paclitaxel. We went back and did an analysis according to the Oncotype DX recurrence score. And what we found, this is, we're looking here at breast cancer-specific survival by nodal status. And you can see on the left patients with 1 to 3 positive nodes, and on the right patients with 4 or more positive nodes. And the fact is that patients in the blue line that had 1 to 3 positive nodes and had a low genomic score, Oncotype DX less or equal to 18, and on the right side we see 4 or more positive nodes. The blue is the low, the orange is the intermediate, and the green is the high recurrence score. So what you see on the right is patients with 4 or more positive nodes, but the non-cotype score of less than 18, the low, had actually better outcomes than what we see on the left curve, where patients with 1 to 3 positive nodes with intermediate or high oncotype score had worse outcomes. In other words, the recurrence score was a better predictor of outcome than the number of positive nodes. And if you have 4 more positive nodes but a low recurrence score, you did actually pretty well. So the question is, do you need to give chemotherapy to these patients? Of course, the question is, do they benefit from chemotherapy? And here we have another prospective study, the SWOG 8814, that was a study of CAF plus tamoxifen versus tamoxifen alone for patients with any number of positive nodes, postmenopausal. And what that study showed when we applied the recurrence score was that the benefit from chemotherapy came from patients that have recurrence score of 31 or greater, we see on the right part of the 3 curves. But with recurrence score of under 18 or 18 to 30, there was no benefit from chemotherapy. And these are patients not only with 1 or 2 or 3 positive nodes, but also 4 or more, so any number of nodes. So that tells us that the genomic profile is more important to predicting benefit of chemotherapy than the actual risk of the patient because of the number of positive nodes. What about the monarchy results? How does performing axillary dissection alter the patient management for the monarchy? Well, patients, again, for 1 to 3 positive nodes that do not meet size or grade criteria, like our patient here, they may become candidates if they have 4 or more positive nodes. But this is a smaller subset of patients because it also excludes patients that have 5-centimeter tumors or greater, or grade 3 or Ki-67 over 20%. And of course, we know that application of Ki-67 as well as the 21G recurrence score may further help clinical management. In other words, may put the patients in a low risk category. So the first question you have to ask ourselves is, what is the likelihood that patients with 1 to 3 positive sentinel nodes will have a total of 4 or more positive nodes on axillary lymph node dissection? And when you look at several databases here from the ACOSOC Z11, the Memorial Sloan Kettering series, the second, couple of the NCTB databases, the Institute Curie, and more recently the Senomac trial, one of the sentinel lymph node biopsy trials for positive sentinel node patients, we see that overall about 15% of the patients that have 1 to 3 positive nodes on the sentinel lymph node biopsy are found to have 4 or more sentinel nodes on an axillary lymph node dissection. So remember the number of 15% because that's important. It's very consistent across trials. And of course, the number is going to get even better if you do axillary ultrasound before you do the sentinel lymph node biopsy, which wasn't done in some of the older studies. And then, can we refine this even better? And some of the studies actually looked in more detail. Like, for example, in the NCDB study, they said, what is the rate of 4 or more positive nodes if you have only 1 positive node, 2 positive nodes, or 3 positive nodes? And as you can see, the numbers go from 9.6 with 1 positive sentinel node to 24% with 2 and 50% with 3. And then in the Institute Curie study, they identified factors that increase the likelihood of 4 more positive nodes, like tumor over 2 centimeters, or 2 or 3 positive sentinel nodes, or invasive lobular carcinoma. And we see the effect of the number of positive nodes, but also the effect of removed lymph nodes. So in the y-axis is 1, 2, 3 positive nodes, and in the x-axis is 1, 2, 3, or more than 3 removed lymph nodes in the sentinel lymph node biopsy. So that affects, for example, if you had 1 positive node, but there were more than 3 nodes removed, like in other words, 1 out of 4 sentinel nodes, only 2% of those patients will have 4 or more positive nodes if you had an axillary dissection. If you have 2 positive nodes and you only remove 2, there was a 41% chance. And then if you remove 3 or more than 3, it went to 21 to 16%. And then, like for our patient here, if there were 3 positive nodes out of 3, then there was a 70% chance of having more. And because this patient that we have here was 3 out of more than 3, 4, at least a 50% chance that this patient has more nodes in the axillary dissection. So you can see how you can try to estimate better. How many patients would need to undergo axillary dissection to find one who benefits from chemotherapy, let's say, in the responder trial? So let's play this along. We say premenopausal patient that was in premenopausal. So in this case, it doesn't really matter because it was postmenopausal. But let's say a premenopausal patient has an IDFS benefit of 5%, so 1 in 20 benefits. And then there's a 15% chance of having 4 more positive nodes, so 1 in 7. So you multiply this, how many axial lymph node dissections you need to do to prevent one IDFS event in the responder trial for premenopausal patients, not for the patient we're talking about here. And as you can see, the numbers are staggering. 133 axial lymph node dissections to prevent one IDFS event, 230 to prevent one distant recurrence, and 513 dissections to prevent one death. So that doesn't make a lot of sense. And on the opposite side, if you did that, 27 more patients will get lymphedema for one IDFS event, 46 for one distant recurrence, and 103 patients will get lymphedema to prevent one death. So it doesn't make a lot of sense. Now, if we look at it in the monarchy trial with abemaciclib, again, here we know 1 to 3 positive node patients on sentinel lymph node biopsy. The IDFS benefit on the monarchy was 7.6%, so 1 in 13 patients. And then 15% had more nodes, 1 in 7. Multiply this, how many axillary dissections, and you can see the number here. 88 axillary lymph node dissections to prevent one IDFS event, 99 to prevent one distant recurrence, and of course there's no overall survival benefit, so you cannot even calculate, but you do cause considerable lymphedema. So you understand that axillary dissection is a morbid procedure, and at the end of the day, to benefit, you have to do a lot of dissections to find one patient that benefits, and you have to cause significant lymphedema. Now this, at least for the CDK inhibitors, may this problem may go away because now we have data from another trial, the NATALEE trial, that evaluated adjuvant ribociclib for 3 years. And the criteria for the study were looser than the criteria of the monarchy. For example, they included high-risk non-negative patients with a grade 2 and an evidence of Ki67 over 20%, oncotype DX 26 or greater, or high-risk via genomic profiling, or grade 3. And also they included all N1 patients. And of course, higher stages as well were included. And this study obviously came a little bit later than the monarchy, so we have a little bit less follow-up. But recent updates of the data from this trial also show a benefit in favor of the CDK4/6 inhibitor. There's a 4.9% absolute benefit at 4 years. And again, the risk of invasive disease was reduced by 28.5% with ribociclib plus a non-steroidal AI versus a non-steroidal AI alone. And interestingly, this benefit was shown whether it were non-negative patients with high-risk features or even N1 to 3 patients. So the patient like ours here would have expected to have about a 5% benefit at 5 years with the addition of ribociclib. So that problem in terms of doing more surgery, which we never thought it would be a good idea anyways, but eventually will be going away now that we have data to say that even in N1 patients, they benefit without having an axillary dissection. So what are some of the key takeaways from this presentation? Although a minority of patients with positive sentinel nodes may be understates by not having an axillary dissection, the totality of the data suggests that this does not mean that they will be undertreated. And although axillary frontal dissection may be considered in individual patients being managed by a multidisciplinary team, I think routine axillary frontal dissection is not indicated to safely apply the results of the Responder, Monarchy, and NATALEE trials to determine systemic therapy recommendation in this postmenopausal HER2-positive breast cancer patient. Thank you for participating in this activity, and please continue on to answer the questions that follow and complete the evaluation. Thank you very much.